Thank you so much, Dr. Kakar, for the invitation. This is really a phenomenal meeting. Wow, it's fun. It's going back to my roots in pediatric HIV from many years ago. What I like to do is bring a topic to your attention, which is really, really important. And with my conversations at lunch with a couple of you, that perhaps this needs to be emphasized. And so I really appreciate the organizers paying attention to resurgence in congenital syphilis. I'm going to call it the enduring pandemic. I have nothing to disclose. 5 things that we'll touch upon. I don't think I'll have time to do all of them. Epidemiology, clinical presentation, just some brief snippets on that. Treatment guidelines, very brief. Point of care testing, which has been a major advancement that has come out of WHO for many years now. And then if I have time, I'll talk about the syphilis vaccine development. Let's go back to 1969, and this is Hartford, Connecticut. And these were photographs that were given to me by Dr. Leon Kamaitis, who's a pediatrician in Hartford. And he saw this patient in 1969. And you can see this is a baby who died of congenital syphilis. You can see the stigmata around the face, the lips. Baby's swollen, a little hydropic. You can see some lesions in the back of his leg. And unfortunately, you see a liver that is very bloggy. And this is exactly what T. pallidum can do. T. pallidum can kill you. Now, move to 2015 to my home country of Colombia. This is from Adriana Cruz and Silvana Castillo, who lent me the pictures of this baby who was 34-weeker, 2.2 kilogram, 3 prenatal visits. They ordered the RPR, but it was never done. Shows up with an RPR 1 to 32, and the skin lesions that you see and desquamation. This patient obviously had congenital syphilis. Missed opportunity, should have been treated before the baby showed up. Let's talk about the epidemiology. And again, I apologize, I don't have data from many countries, and that's a call to you. And this is a group that represents many countries in the world to come together and actually come up with a real map of the epidemiology of congenital syphilis. What I'm showing you here is venereal syphilis, and you can see the syphilis epidemic is global. This is from Rosanna Peeling, a great paper that I urge you to read in Nature Reviews in 2017. And what you can see here is that this disease is all over the place. You look at the Americas, about 1 million cases. You look at the African region, 1.8 million cases. The Mediterranean, 500,000. All the way Southeast Asia, 1 million. So this is a tremendous problem that has continued to spread, and we have not controlled it. About 18 million individuals have syphilis, 15 to 39, and about 8 million new cases per year. Now, back in 2011, we did a study with my colleague Adriana Cruz in Colombia. And this is a small town, Buenaventura. It's not small. It's got a population of about 369,000, about 5,000 to 6,000 births. And we did a case review in their hospital, and we found that in one single year they had 196 cases of congenital syphilis and 12 perinatal deaths. A tremendous problem that was under-recognized. And in this case, it was this, the societal issues that lead to this. And there was a lot of issue with narcotics at this time in Colombia, and a lot of displaced, very poor people. And it ties into venereal syphilis. This is one of those diseases that is tied to socioeconomic conditions, unfortunately. Now, there are 3 papers that, if you're interested in this, you should read. One is in PLOS Medicine from Laurie Newman and Natalie Brutet. The other one is in PLOS 1, published in 2019 from Monica Alonso. And then the last one is in Lancet Infectious Disease from 2024. And this gives you a lot of information, but what you will notice is there's a lot of missing information. But what we can gather in the last 7 to 10 years, is that there are about 1.3 million cases of gestational syphilis. These are moms that are newly infected with venereal syphilis. And congenital syphilis, more than 600,000 cases per year, about 500,000 deaths. I want you to record that into your brain, 500,000 deaths. And of those that survive, we have about 250,000 children that are diagnosed with congenital syphilis. If they're treated, they're lucky, but not all of them are treated, unfortunately. And the global rate right now is 425 per 100,000. The target from WHO is 50 per 100,000. So we are in trouble. We are in trouble, guys. And I want you to pay attention to this. As you do all your HIV testing, you need to be thinking of venereal syphilis, and you need to be thinking of gestational and congenital syphilis. Now, this is directly from the WHO website. This is from 2 days ago, and this is the rate per 100,000. This is a live map. And what you can see here, two things. One, there's a lot of missing data. The countries in white are not reporting to WHO or have not reported yet. And then you can see the rate per 100,000. The darker colors in Latin America, unfortunately, my home country of Colombia is in the dark there, but you can see many countries in sub-Saharan Africa, but there's a lot of missing information from Africa. There's a lot of missing information from Europe and across the world. So we have a problem of reporting. And I've asked a couple of your colleagues here in the audience if they had seen anything recently, and they said, not really, not too much of a problem in Africa, but the reality is that this is a huge problem. Now, obviously, we're here in Germany, and they went to the European CDC, European Union CDC, and you can see here that while in 2019 there seemed to be a decrease in cases of congenital syphilis, in 2021 and 22 that has increased. And I'm going to predict that over the next 3 or 4 years you're going to see a dramatic increase in Europe, just like we have seen in the United States. Now, you would think the United States has a lot of resources, a lot of diagnosis, a lot of treatment. We should be in good shape. We're not. This is the most recent data from the US CDC. You can see congenital syphilis reported cases by year of birth and rates. On the left axis, you can see the number of cases in the thousands, and on the right is the primary and secondary syphilis rate for women, 15 to 44, and both go hand in hand, obviously. So in 2022, an appalling number of 3,700 cases of congenital syphilis with deaths in the U.S. because of this disease, and the rate now is 102 per 100,000 live births. So this bacterium does not pardon you. It does the trick. It keeps moving, and you got to pay attention to it. Now, in the U.S., not surprisingly either, American Indians and Alaska Natives have a rate of 644 per 100,000 live births. This is also a problem, and again, tied to socioeconomic conditions, lack of access to maternal care and prenatal care. It does affect primarily the African American Black population, and the number of cases are in the thousands in this population. So hopefully I convince you that this is a problem, a call to arms to get more information, and each of the countries represented here, please contact me. I'd love to do something that is more broad and actually has real numbers. Why does this occur? This is a nice publication, Curious. If you haven't seen it, you should look at it. And what it does is it shows you that T. pallidum affects babies all the way through the time of conception, perinatally, postnatally, and if you don't treat the child, obviously later than 2 years later, you have late onset congenital syphilis. Why does it occur? Early congenital syphilis is due to hematogenous spread of the organism, which results in inflammatory responses in various organs and tissues. The mothers are spirochetemic. It's in the blood. It goes through the placenta. It leads to extramedullary hematopoiesis, immune-mediated complex disease, and if you don't treat this, then you have the late-onset congenital syphilis manifestations, which I'm not going to have time to talk about. The primary route of transmission is in utero. This is the transplacental route. And different from HIV, this pathogen is really well adapted. It goes right through the placenta. Remember, in the old days of HIV, 20% transmission untreated. With venereal syphilis in moms, it's close to 80–90%. So this thing goes right through. Now, obviously, you can get infected intrapartum if you have a genital lesion, but that's the least likely way of transmission, and it does increase with the stage of pregnancy. And this is a nice study done by Pablo Sanchez, my colleague and friend at Nationwide. Well, he was in Dallas, and what you can see here is that in secondary syphilis, you have transmission rate of about 60% of the moms not treated. 26% perinatal deaths, 34% congenital syphilis, but it occurs in primary, secondary, early latent, and late latent, so it keeps going. Now, why does this maternal-fetal interface, which is a formidable way of prevention of CMV, HIV, If it wasn't for this, we would have 100% HIV transmission. It prevents it there, but look, in congenital syphilis, it fails. Now, we don't know this. We're beginning to study this, and I won't have time to go into details of all the studies, immunologic studies with the placenta that are ongoing right now. But I will focus on one specific thing. You need to learn about the bacterium. Now, T. pallidum is a spirochete. It's not a gram-negative. It's not a gram-positive. It lacks LPS. That's lipopolysaccharide that's present in E. coli that I guess was discovered here in Munich. But it doesn't have LPS, which is what causes toxic shock. But it is rich in lipoproteins. But guess what? All those are hiding under the outer membrane. So it's almost denuded. And if you can see the photograph there from my colleague Justin Radolf on the right, that's a freeze fracture microscopy, and you can see there's very few little dots there. If you did this with E. coli, it would be laden. It'll be almost like tons of things on the outside. And if you did this with Borrelia, which causes Lyme disease, you would see a lot of these things. So this is highly invasive, it's almost denuded, and it behaves like a stealth pathogen. You know, you've seen pictures of the stealth bombers that are not detected by radar. This is exactly what this bacterium does. Now, it's really important to treat properly, but it's difficult to confirm a diagnosis. That's a problem. It's hot. You can't really culture it from kids. You can actually culture it in vitro now. We have actually made progress in that, but it's very difficult. You can't really culture it from a baby, and it's difficult to detect. The serologic tests are complicated because IgG, and you've known this for the HIV world forever, the maternal IgG is not going to help you, and the IgM is not very good, unfortunately, in babies. Is there really a lack of a sensitive and specific test for IgM? That's something that needs to be developed. And for neurologic disease, it's really difficult to know who has neurologic disease. So the CDC has come up with definitions. So there's a confirmed case, and I'll talk to you about that in just a second. There's a probable case, which is mostly what you're going to see in your settings. And then, of course, there's a syphilitic stillbirth, which is a fetal death after 20 weeks gestation with a birth rate of greater than 500. But what's not here is all the children that die in the first trimester, and there are many who go undiagnosed, unfortunately, because of venereal syphilis in the mom. Now, scenario one is a proven or highly probable case of congenital syphilis. The exam is abnormal and consistent with congenital syphilis. You can have a positive dark field or fluorescent antibody in the fluid, positive PCR, or a positive rapid infectivity test, or a positive immunohistochemistry. And let me give you an example. This is Hartford, Connecticut, again, 2022. This is a baby that was 33 weeks gestational age due to congenital syphilis. You can see there petechiae in the abdomen. The baby is somewhat bloated. Color is ashen. And we were able to see in the umbilical cord using immunohistochemistry, those little brown things you see there, that's T. pallidum by immunohistochemistry. So this would be a confirmed case of congenital syphilis. And this mom came in late without a prior diagnosis and unfortunately developed congenital syphilis with complications. Other clinical manifestations, so you might have seen this, you probably have, hepatosplenomegaly, the rash, condyloma lateral, snuffles, jaundice, pseudoparalysis, and hydrops. And this picture is very common. It's shown in most of the textbooks, the snuffles. You have broken vesicles, desquamation, and these kids have a lot of spirochetes. If you do a dark field on that fluid, you're going to see spirochetes galore. You have papulous squamous plaques. And again, this is from the one on the left there is from that original baby who died in Hartford, 1969, but similar rashes. So if you see this in a baby, be suspicious for congenital syphilis as you do for other torch infections. These babies should have a lumbar puncture, a CBC, platelet count, bone x-rays, and other tests which are relevant, and I won't have time to go into them. Now, here's a big issue. This is from my colleague, Ian Michaelo, who's now the head of infectious disease at my hospital. And he published in 2002 as a fellow a great paper where it shows three things that are really important. 41% of those with abnormal clinical laboratory radiographic findings have a confirmed case of neurologic disease, so very high. 60% of those with abnormal physical exam findings. And 3 infants who had normal CSF indices. So you do a spinal tap, protein looks fine, cell looks fine. 3 of them still had neurologic disease. So you really can't rely on the specific test in the spinal fluid to rule it out. So you have to treat them as if they were infected in the central nervous system. If you look at long bone x-rays, you'll find periostitis, osteochondritis, very abnormal. Now, you don't really need to do this to make the diagnosis, but again, if you do, it just shows you how disseminated this bacterium really is. How do you treat this? Penicillin, penicillin, penicillin. And guess what? There's a shortage of penicillin. Amazing, right? I mean, this is absolutely crazy. In the US, there's a major shortage of penicillin. We have to save penicillin in case the baby comes in. And I think there's a worldwide shortage. And unfortunately, we don't have really proven alternatives. So we were talking, I've heard this morning about, making sure that some of these drugs are tested, and we absolutely need to test ampicillin. We need to test ceftriaxone, limited data. Trials are ongoing right now. Now, this is the most likely presentation, asymptomatic. The infant born to a mom with untreated or inappropriately treated venereal syphilis. I was chatting with my colleagues from Children's National. Said most of the babies they see in DC are asymptomatic. So what is the likelihood they have congenital syphilis? Well, go back to Pablo Sanchez. Really nice study. Didn't publish it, but I have the data here. And so why evaluate and treat asymptomatic infants born to mothers with untreated syphilis? He did the study, and look at this. If you look at serum and blood, 16% had a positive IgM, 3% had a positive CSF, and 7% have a positive rabbit infectivity test, which means that fluid from those babies injected into a rabbit testicle was positive. So even if the baby is asymptomatic, you have to treat him if the mom has been untreated. Now, what if the mom is treated before 4 weeks before delivery, which is another part of the guideline? Well, once again, if that mom receives treatment 2 weeks before, 3 weeks before, there's still a possibility that baby will be infected, and therefore you need to treat. So that's not reliable. It has to be more than 4 weeks. So you must treat if the following parameters are true in the asymptomatic infant. Maternal treatment, none, inadequate, unknown. If they use erythro, azithro, and non-penicillin drug treatment, you need to treat the infant. Azithro is not very good, a lot of resistance. Treatment less than 4 weeks before delivery. If the mother is reinfected, here's the issue. Moms can get reinfected. This is the bacterium that has a problem. You can reinfect it over and over again, even if previously treated. And the infant's RPR titer is less relevant. That's something I always get asked. Whether the RPR is XY, I don't worry about that too much. Worry about the treatment of the mom, proper treatment of the mom, and I think you can make a diagnosis and recommend proper therapy. The evaluation you know and the treatment you know. Now, penicillin allergy, it does say to desensitize. The data is insufficient currently to recommend other agents. Call to action to do studies with ceftriaxone, very important. We need to do that. But if non-penicillin agent use, close serologic and CSF follow-up. Many people who are truly allergic to penicillin are not allergic to cephalosporins. That's an important fact. HIV infection, relevant to this conference, infants born to mothers co-infected with HIV do not require different evaluations, the same one. Same therapy, same follow-up as venereal syphilis. And again, we talked about penicillin shortage. Now, how do you prevent this? Best thing is prenatal care, obviously. You need to get moms in. Rapid tests, I'll show you what we have done in the past. But you have to treat the partner. This is not just the mom. The partner is really part of it. Moms can get reinfected, and if we just treat the mom, it's not enough, and that's part of the problem. Now, serologic screening should be done twice or 3 times, ideally. First prenatal visit, 28 weeks. In high-risk areas, and that's most of the U.S. right now, you should do a test at the time of delivery. Don't miss that. Do not discharge the infant without maternal serologic status, documented at least once during the pregnancy. That's where we miss them, and they come later with hearing loss. And obviously report the cases. Most countries are not reporting. It's not a reportable disease, unfortunately, in many countries. Now, point-of-care testing is something WHO has pushed, and I fully agree with this. And this is what needs to be done. This is a study we did in Haiti many years ago, published in 2009, where we found that the estimated congenital syphilis rate in Haiti was 767 per 100,000. And this is in Jeremy, which is in the southwestern part of Haiti. This is Jeremy, which is the city of poets. Unfortunately, not really a city of poets. It's a very poor area. But they do something remarkable. They actually go out to the communities. This is a small little town in Haiti. And what you can see here is the health workers go out there and actually do the rapid test. And in this, I happened to be there that day, and they actually had a positive test. They asked me to look at the mom. The mom had secondary syphilis, looked at her hand, she had a rash. They were able to give penicillin immediately here. They didn't worry about allergy testing for penicillin, just went ahead and did the test. That saved that baby. Otherwise, that baby could have died. So there is an algorithm for syphilis testing with a rapid test. I encourage all of you to be really familiar with this, and if you have a rapid point-of-care test, treat immediately. That's the only thing you can really do. In the U.S., what the strategy, in the U.S., we don't do this, by the way. We really can't do this point-of-care test. It's ridiculous, but that's the way it is. So what they're doing is test, retest, and treat and retreat. I mean, that's the strategy right now because we are sort of in desperation. And I have about a minute and a half to tell you about the vaccine. I could spend 3 hours, okay, but I'm going to do my best. So everything has failed. We really need a vaccine. The vaccine is very difficult. Any disease, and you know it from the HIV world, right? You've been trying to develop an HIV vaccine for, I don't know how many years now, billions of dollars spent. You haven't achieved, maybe some success, not a whole lot of success yet. And so I apologize if somebody has an answer that's not meant to be an insult. There are very few of us syphilologists, and yes, I am a syphilologist. There are about 5 in the world. And we work on this because it's really hard to do, but we've made some progress, and I'm very proud to share with you. This is the team. Is led by my colleague Justin Radolf and Tony Moody, who's an infectious disease immunologist at Duke. And we have a big team supported by the NIH and the U19, which just ended. We got a U01 follow-up to continue the work. Not nearly enough. Remember, $1 billion were given to pharmaceutical companies for COVID vaccine. We got an $11 million grant. Okay, the disease is a big problem. So not enough money, but at least we've made some progress. And this is a collaboration between Columbia and Institute Sinaim in Malawi with Chapel Hill and UNC, and also in China, in southern China, in Guangzhou, with our colleagues at Southern Medical University. And what we have done now is actually fully, and I'm running out of time, but I'll just take two extra minutes here. What we have done is fully identified true outer membrane proteins of T. pallidum, and I'm listing them all there. There are various families and subfamilies. And those that are called FAT-Ls, those are the ones that are of interest. And we have to do a worldwide molecular epidemiology to see if these antigens that are on the outer surface of T. pallidum are conserved or not, and we're focusing specifically on the extracellular loops of those proteins that we think are immunodominant. We made a lot of progress in the structure of the organism. We're beginning the animal studies right now, and hopefully within 5-7 years or sooner, if we get more financing, we can actually begin some human trials. And again, what we have to do is starting point is build a syphilis clinical research consortium, and we have done that. We collect the samples. It's really hard work, and we have done this through the pandemic. And we now have a number of strains where we can actually do sequencing and then focus on the outer membrane proteins, focusing on the loop variability and making sure they're truly antigenic so we can begin creating a cocktail. And it's an approach that's complicated. The patients come in with venereal syphilis. We do the swabbing, then we do the extraction, we do the sequencing, and then we go to our genomics core, and we have identified variability within the loops, and then we're doing the immunologic studies with a worldwide campaign. Now, what we do know is that this is going to require not a single antigen, but it's going to require a cocktail of a variety of antigens. Again, because many of these are not really expressed in significant number in the outer membrane protein, there is some variability. There is regional variability on the outer membrane proteins, and so the cocktail is will hopefully be something that will help. But again, with the experience with HIV, we know that this is going to be very difficult. And learning from nature, we know that people develop antibodies, and guess what? The higher titers of antibodies occur during secondary syphilis, and yet the disease continues. So nature tells us that this is going to be difficult, just like in HIV, but I think we're hopeful that we can come up with something that actually will be useful. And with that, I'm 2 minutes over time, but it's okay. And this is the team that has put this together all over the world. And I'm really, really happy that you invited me to at least share some of the thoughts about congenital syphilis, venereal syphilis, and vaccine development. Thank you.